And so we're going to start with, I'm going to actually start with chronic renal failure. I'm going to start there. I'm going to share my screen with a case study, or I'm at least start with fluid volume excess, not necessarily chronic renal failure, but we're going to talk about that too. All right, so looking at fluid volume excess. So here's a case study. And so here's your case study. Oops. So you have Miss Jones. She's a 63-year-old retired nurse who enjoys playing card games, traveling with her husband. She's postmenopausal. She's on estradiol hormone replacement therapy and a daily baby aspirin. The only other medication she has is a transdermal scopolamine patch to prevent and relieve seasickness for her upcoming cruise. 3 days into the Alaskan cruise and her bridge tournament, she begins to feel as if her heart's fluttering. She gets dizzy. When standing, she has mild leg weakness, becomes short of breath when climbing the ship's stairwells, and has noticed her feet and ankles are becoming edematous. Mrs. Jones visits the ship's nurse for evaluation and discovers that her blood pressure is slightly low, 100/66, heart rate's 80, and her respirations are 18. So the nurse decides to remove the scopolamine patch, clean the area with some mild soap and water. She's admitted to the clinic and encouraged to drink 3 glasses of water and ginger ale. Several hours afterwards, she starts to feel better. There's no longer any dizziness. She's able to ambulate to the bathroom without assistance. She's released from the clinic and the nurse reminds her to have periods of walks, hard sets, drink plenty of water, and non-caffeinated beverages. And then to come back if her symptoms get worse. So what's going on with Miss Jones or Mrs. Jones?
Well, her heart is fluttering and she's dizzy while standing.
Okay.
She's shortness of breath when climbing the stairwell, and her legs are becoming edematous.
So does she have too much fluid, too little fluid? What's going on?
Too much.
Fluid volume overload.
So she does have fluid volume excess or overload. What other signs and symptoms would you anticipate her having besides what they've listed here? Or what other things could you assess for if you're thinking your patient has fluid volume excess?
Lung sounds.
You can auscultate breath sounds. Yep. What else?
You can check for what did she say, lung sounds or bowel sounds?
Lung, L-U-N-G-S.
Would you check bowel sounds to see if has any ascites or anything?
Okay, she doesn't have any liver issues.
Oh, okay.
But I mean, that would be appropriate if this was somebody that we were worried about having some type of liver dysfunction. Okay.
What about edema?
So she did have edema. Remember her right here, her ankles and feet were edematous. So, we have that. She's short of breath. We have that while she climbs the stairs. Her heart's fluttering. So I'm just asking about other things that would be indicators of volume excess or volume overload. So, Nico said to check lung sounds, which that is definitely appropriate. What other things would be indicative of fluid volume excess?
I'm going to check their labs. I'm trying to think which labs. Would you check their sodium levels?
Okay, we could. But what about your assessment? We're just talking about what other assessment findings Not that she had them, but what other assessment findings would help you?
Would it be would it be distended veins,
She can have, well, not vein, well, which veins?
neck vein?
Okay, so she could have JVD, jugular venous distension, or engorged neck veins. That's another word for JVD, but the JVD stands for jugular venous distension. So that could definitely be something else you would look for. Anything else?
Would it be a bounding? No. It would be a faint pulse.
Actually, you were right the first time. It'd be a bounding pulse.
Okay.
Because usually when it's thready, we have less volume, right? When the pulse is weak and thready. So when we
would she have weight gain because of all the fluid?
right, but that's the edematous or the edema. So from assessment findings, bounding pulse, because if it was dehydration, then she would have a weak and thready pulse. So make sure that you know the difference of when they're dehydrated, what the pulse would feel like, and when they're overloaded with volume, what the pulse would feel like. Okay? Because they're opposite. Then we would check for jugular venous distension, and then we would also check for this breath sounds to see if they have any rails or crackles. So the next question would be, what medication would you anticipate them potentially giving her?
Lasix.
So she could get furosemide or Lasix, and getting furosemide or Lasix, then you would expect her to have a decrease in crackles. But more importantly, you want to look at how much urine she's putting out. So you want to monitor the INOs for that. Make sure we don't now tip her on the other side. So let's look at our case analysis. So although she has classic symptoms of heart failure, what lab value would tell us about heart failure, by the way?
There, is it
Troponin.
No, that's like heart attack, but we're looking now for heart failure.
Would it be CMP?
No, because that's the cardiac metabolic panel or chemical metabolic panel. That's like your sodium and all of that.
But I don't know what it's called, but I know you can tell from their injection.
BNP.
It'd be the BNP, the brain natriuretic peptide. So I'm gonna stop sharing here. Ooh, crackles on, yep, okay. So let me share. Okay, so you should see a whiteboard up here now. So let's see. Move my hand down. So you should see a BNP, which is the brain. Yep. Let's see. Yep, I gotta erase that. Oh, eraser. There we go. So it's not quite like the whiteboard in class, but it'll work. So the BNP, what's normal? What's our normal BNP? so less than 100 picograms per milliliter. So basically any number greater than 100 equals heart failure. So if you have 1100, is this a little bit or a lot of heart failure?
A lot of heart failure.
It's a lot. Okay. So basically that number should be less than 100. But if it's greater than 100, then okay, we have, is basically like Houston, we have a problem. Okay. So it also predicts, mortality in individuals as well. So any type of high BNP, we want to make sure we're doing a cardiac assessment. And so since this is about heart failure, then we're going to, check breath sounds. And we're going to check for edema. We're going to check for JVD. And we're going to check for dyspnea. Those are all the things we're going to check for. Does that make sense? Questions about that? But if they have increased fluids, so FBE, then these are all the things we're going to check for, and then we should anticipate them having a bounding pulse. Questions? All right. Hit stop share. And then we'll go back to, I have to share this document again. I'm going back to the case study. All right. So bringing back up the case study. So she has heart failure. So we need to get a medical history, her current medical status, her level of activity to determine the true nature or origin of why she's struggling. Extracellular or extra fluid volume excess in the lower extremities. Now, that could be because she's been dependent and sitting for some time, long periods, as well as the side effects of scopolamine, which is swollen leg. Patients over 40, they should use cautiously because it changes the metabolism. It won't be one of the routine ones that they give. Okay. So if you have patients that are, that have an excess in volume, check their electrolytes and all of those things. Okay. So that kind of segues into chronic renal failure. If you have somebody in chronic renal failure, go back to the whiteboard here. We'll stop sharing and then we're going to go to share the whiteboard. All right, so if you have somebody in chronic renal failure, then, what's actually the issue when people have chronic renal failure? What structure is being affected? So we're talking about chronic renal failure. So if a patient has chronic renal failure, what's not working?
The nephrons.
So the kidneys aren't working because they have a decrease in the number of nephrons. So that's where the urine is made. They're basically destroyed. Okay. So any remaining functional nephrons that exist, they're going to be dysfunctional. They're not going to work the same. So the glomerular flow and pressure will increase in these nephrons that are remaining. And what they'll end up with more solutes that's going to be filtered to try to compensate for the renal loss. Over time, once you lose these nephrons, they do not regenerate, rejuvenate, however you want to put it. So they're dead and gone. Okay. But the kidneys now kind of become very sclerotic. And now, the urinary output will start to decrease. So that'll be oliguria or become oliguric. What are some reasons, some causes for chronic renal failure?
Hypertension.
Okay, so hypertension, diabetes. Right now, my friend has this condition, polycystic kidney disease, and he's currently awaiting a transplant. Oops. So, let's see. So you also have lupus. So that's the systemic lupus erythematosus. Or SLE. And if someone has long-standing hypertension, remember heart failure, kidney failure, that can happen. Having the glomerulus be inflamed all the time, then that can end up with a lot of nephron loss and the kidneys will shrink. Polycystic kidney disease, basically there's multiple cysts that develop on the kidneys and destroys the normal tissue of the normal renal tissue because it's being compressed by these cysts, and that happens on both of the kidneys. And with your lupus, there's damage to the basement membrane by the circulating immune complexes, so this can now cause issues with the glomerulus as well. So as renal function declines, then the end products of protein metabolism end up accumulating in the blood. So that's when you end up with uremia, right? So the patient will have uremia. As that continues, which is basically the end products of metabolism, of protein metabolism. So the key is to try to control the blood pressure, the diabetes, the excretion of protein in the urine to try to slow down the damage done to the kidneys. But once chronic renal failure is diagnosed, then basically the goal here is to prevent the disease from progressing to end-stage renal disease. So I believe in your PowerPoint readings, there's several stages that they list, 5 stages of chronic kidney disease, and it kind of goes through and tells you what the glomerular filtration rate is, what's actually injured, and how they end up to kidney failure, which is stage 5. and that's classified by the National Kidney Foundation. So at stage 5, the kidneys can't remove any of the waste products or perform any type of, kidney function. So therefore, renal placement therapies like peritoneal dialysis, hemodialysis, or kidney transplant would be needed in order for the patient to live. To try to slow the progression, again, treat the high blood pressure, the anemia, the hyperglycemia, and look for protein in the urine. Is this a cheap disease? And when I mean cheap, I mean like economic wise. Is this a costly disease?
I would say it'd be costly.
It is very costly. Think about all the dialysis. So peritoneal dialysis, they could do that at home. But if they have to receive hemodialysis, then they are going 3 times a week, either Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday, but they get a 2-day break in between. And with that peritoneal dialysis, when they're, how do they determine how much to pull off? Well, the nephrologist, he makes a decision, he or she. So the nephrologist will determine the patient's dry weight. So say, for instance, it's 70 kilos. So they're going to determine the patient's dry weight. If the patient, when they go to dialysis, say, for instance, they weigh 76 kilos. Okay. So this is, at dialysis. If this is 6 kilos, almost 12 pounds, roughly. So if this person has 12 pounds worth of water, it's going to take some time to pull that off. There's a lot of shifting of electrolytes and fluids and all of that happens. So they're going to try to pull off as much of this 12 pounds that they can to get them back to the 70 kilos. So that's why patients that receive dialysis, that first day after dialysis, from all the fluid shifting, they can have chest pain, they can have abdominal pain, they can have nausea and vomiting, they can have low BP. So they go through that every second day. So just imagine that. So then, that's the day they get dialyzed. So the next day they feel good, but then you really can't feel too good because you know what's happening on the next day. Does that make sense? And at one point you couldn't even travel if you were on dialysis, but now you can set up your dialysis treatments in the town that you're going, even on cruise ships and all of that. So they have at least stepped up their game related to that piece. What population of folks are at the highest risk of developing chronic kidney or chronic renal failure?
African Americans.
African Americans, Native Americans, Asians, European Americans, they have a higher risk of high blood pressure. So this puts them at risk of chronic kidney failure. Okay. So if you don't think your kidneys do a lot, they do. Let's clear that. The kidneys, regulate your blood pressure. They get rid of waste products. They get rid of excess fluids. They manage your fluid and electrolytes. They keep that in balance, your acid-base balance, metabolizes your vitamin D. So there's a lot of different things your kidneys do in addition to stimulating red blood cells. So, medications, illnesses can put patients in renal failure, but before they get to failure, they call it the AKI, which is acute kidney injury. So, toxic agents like snake venom, recreational drugs, people that drink antifreeze, they can end up in kidney failure. Vascular disorders can affect renal blood flow. So, if they have venous insufficiency, arterial insufficiency, then that can bring about chronic kidney disease later on. Medications that are toxic to the kidneys, like your mycin antibiotics, they can actually bring on kidney disease. Untreated strep throat. So if you get strep throat and you don't get it treated, then what it will do is it'll fry out your kidneys. So that bacteria will go to the kidneys and cause kidney damage. So you think you have strep throat, infertility is the least of your worries. Okay. Being exposed to, like, chromium and mercury and lead, those are things that also can contribute to chronic renal failure. So having kidney failure can impact several other areas, cardiovascular wise, your F&E. You have the waste product that accumulates, and so you can sometimes end up with itchy skin. So there's a lot of different areas that end up being affected by chronic kidney failure. And I believe, if I'm not mistaken, your PowerPoint kind of toggles that out for you. But there's a long list of having uremia, and causes and things of that nature. Did you guys not see that in your PowerPoint material?
I saw it.
You think so? Maybe. So with chronic renal failure, besides uremia, oops, hold on. Let me get my little whiteboard back. I don't know what I did with it. There we go. You probably saw my pen moving. I was like, where's my whiteboard? So with CRF, chronic renal failure, so your common signs are uremia and anemia, fluid volume excess, and you can have potassium issues. So should we give them a bunch of fluids to drink?
No.
Nope. So, I mean, that's why they're going to be on a restricted diet. They're going to be on, they'll need a dietary consult to make sure they're getting the calories and the proteins that they need for healing. They're going to have their chemistry metabolic panel. They're going to have that monitored as well to see if their potassium levels are off. If they have anemia, they're not going to be, energetic. They're going to be tired. They may be pale. So if they have anemia, then we need to give them like an iron supplement to treat that. They could use or may need a blood transfusion. For the fluid volume excess, initially they may try a diuretic. Are we going to give them a lot of sodium?
No.
We're going to decrease sodium intake. We're going to restrict fluids. And if we can't fix it with that, then they're going to have dialysis. So potassium would be up or down. It'll be up.
Up.
Because they can't excrete it. Okay. So how are we going to treat potassium? We can give them K-exalate. Right? We can give them D50. Give them insulin. Remember we talked about that for hyperkalemia. A low potassium diet. And worst case scenario, dialysis. So are we all on the same page thus far? What would we expect their BUN and creatinine levels to be, up or down? They're going to be up. Okay. So everybody have this here?
Yes.
All right, hitting clear. All right, moving on, next one. So what are our F&E imbalances? So we're going to have sodium and water retention. We just talked about the potassium is going to be high because we can't pee it off, right? What about our calcium? Would that be up or down? And our magnesium, would that be up or down? You got a couple questions on the table. Would our would our calcium be up or down?
Would it be up? Would it be up?
Our calcium's actually going to be down. Our mag is going to be up.
Robert, you need to send the nurse station.
And because our calcium is up, our phosphorus will be what?
Up.
Yeah, phosphorus will be up. So the phosphorus is up because the excretion of phosphorus is impaired through the kidneys. So that's why it's up. So when it's up, then our calcium is what? Down. So we don't want to give them anything that contains elevated. Impaired vitamin D activation also contributes to the hypocalcemia. The hypermag, that develops with as renal failure continues to advance, and it can't be filtered out. So again, they should avoid magnesium preparations as well as phosphorus. So which acid-base imbalance would chronic renal failure people be in?
Metabolic acidosis.
Correct. There's going to be metabolic acidosis. And that's because our yeah, can somebody mute someone is doing a lot of moving with their microphone, and it is kind of loud. All right, so metabolic acidosis, so our hydrogen ions excretion is impaired, and that's because of the kidneys not being able to flush it out. So as the renal failure continues, then this is going to lead to metabolic acidosis. So we talked about getting the BUN and creatinine, right? We're going to have to get a Chem 7. So these are labs or diagnostics. So Chem 7, that will be should have your BUN and creatinine a part of that. We got to get a CBC. While we're getting a CBC, we want to see what the H&H levels are, see if they're anemic, red blood cells. They may do a creatinine clearance. Oops, hit my erase button. Come on. There we go. And if they still make urine, can they get a UA? Can they do that? They should. So they should get a urine analysis if the patient is still making urine, and a culture and sensitivity. Okay. Any questions about chronic renal failure? Okay, so let's talk about, I want to be clear. So if you have a patient that has chronic renal failure, what assessment areas should you, where should you do your assessment? What body structures? Should you assess?
I would do lungs for fluid volume overload since
Okay.
they're not urinating.
So lungs for sure. Well, Delphine said the same thing. Okay. All right, so check blood pressure. Definitely. INOs, weights, daily weights. Heart rate. So basically just vital signs. Okay. Anything else? What about if they're on hemodialysis? Then we're going to check their shunt. What are we checking for?
The thrill and bruise.
So you're checking the shunt for a bruit, come on, or thrill. So this shunt, now, and I don't mean any disrespect when I say this. When I say shunt, does everyone know what I mean when I say shunt? So in order to do dialysis, they have to create a bigger vein inside the body. So when they do that,
you test it like a pulse if you can feel the throat through it. Oh, hold on. Let me mute. Oh, great.
can you mute that? Okay. So what happens inside the body is that they create this shunt, and so it's kind of like that. I'm going to erase right there. Let me just redraw that. So what's on the inside is like this. So that's the graft on the inside. So you have an arterial side and you have a venous side. But what they do is they put this graft inside so that the volume from the machine, so you have that big old machine with all those buttons, you know, crap turning, you know, all that's going on. And then they have all these little buttons that the dialysis nurse needs to monitor. So in order for this to come in, clean out the blood, and then put it back in the body system, our current vein structure isn't set up for that. So what you're basically doing is you're going to palpate for turbulent blood flow. And then you're going to auscultate for, it's almost like a, it's almost like a cat purring. Does that make sense? Yes, no, maybe. So you feel a thrill, you hear, I said that backwards. You feel a thrill, you hear a bruit. I said that backwards, so let me clean that up. Come on. There we go. All right, so this goes, and so this is more like, I need to change the word here. Sorry, guys. All right, so the turbulent blood flow is the bruit. But you're going to hear it. So this is the one you're going to auscultate. And so for there. So for the thrill, when you palpate it, you're going to palpate this, and it should feel like a kitten or a cat purring. That's what I was trying to say. So that's how you know that the AV shunt is working. So the type of shunt, they call it, is an AV shunt, which is an arterial venous shunt. So those are the two things you should definitely assess your patient for if they're doing hemodialysis. And that's why I have that piece here. That's the blood one. They do that 3 times per week. Okay. So can we take blood pressures in an arm that has an AV shunt?
No.
Can we do needle sticks in that arm?
No.
No. So even as an ER nurse, the nephrologist would not allow ER nurses to stick patients, even if they knew you. They had to put you through training, trust your technique, all of that before they would even consider allowing you to do it. And I can tell you, there was only 1 or 2 nurses that was allowed to actually stick a nephrology patient. So they just don't turn that over to you. But you're still responsible for making sure that you do the assessment on this shunt. So you can't say, well, I didn't touch it. So you still need to palpate it. You still need to auscultate it to see if you hear the turbulent blood flow, or if you feel, the vibration or the cap purring, however you want to put it, going on in the shunt to make sure that it's operable. So speaking about operation, so I'm going to clear this here. So sometimes the shunt doesn't work. And that could be due to a clot. So they may come into your facility if you work in the emergency room to get, to try to get it working by breaking down the clot. So they'll inject a clot buster into the shunt directly. So that may be an option that they do. But what if they say, you know what, this shunt doesn't work anymore? Then they're more than likely they may have a Quentin cath, which is like a temporary double lumen port for dialysis, and I can put that in the chest or in the groin. Or they may have a second AV shunt, and it may be in the opposite arm. So you need to kind of do a double check to see which one is the older one, the one that's not being used, so that way you don't inadvertently mess up the fresh one by doing a bunch of blood pressures and all of that. Okay. What are some risk factors or complications related to, accessing an AV shunt? Correct. Infection is one. It's like your number one issue. So you have infection. You have bleeding. So difficult to control post-dialysis. Anything else? Damage to the shunt. And that's usually when you usually see a patient, someone who has a shunt, and then it has like a little rise in the skin, and then another little rise in the skin. So this means that, the dialysis nurse basically kept sticking the same area over and over and over, so they ended up with a pseudo aneurysm. So that can also happen, which is a pseudo aneurysm. So that's what that is, from being stuck in the same spot. So bleeding, infection, infiltration, all of those would be things that you would be monitoring to make sure the patient doesn't have. All right. It's not uncommon for them to receive erythropoietin. What is that? What is that medication?
Is it iron?
Well, it's not necessarily iron, but what it does, it helps to stimulate the production of red blood cells. But this takes about 4 to 6 weeks. So it's not like, packed RBCs. Okay, correct. So the goal, if they are to receive it, is for their hematocrit to be maintained between 33 and 38%. and they want their hemoglobin to be right at 12. So if you have somebody with that, we don't need to give them any extra blood or anything like that. We're good, okay? Other therapies that they'll receive, they may get calcium and phosphorus binders, either or both. They may get blood pressure medications, so antihypertensives. Anti-seizure medication. Folic acid. A multivite. And that would be in addition to the folic acid and iron. There we go. So if our hemoglobin and if our hematocrit is between 33 and 38, we don't need erythropoietin. They will only get it if the hematocrit, so I'm just going to put given if hematocrit is less than 30. So that's when they start pulling out this med. Okay. So let's look at what we're going to feed them. So what type of diet should they be on? Oh, that finds me up. So they should be on a renal diet. Heme food, okay. Organ meats. Okay. So what's the purpose of the renal diet? Because as the kidneys start to fail, then their ability to eliminate water, solutes, metabolic waste is also going to be impaired. So the dietary modifications can slow the progress or the progression of the nephrons being destroyed. It can also reduce their ability to become uremic and help prevent some of their complications. So with the renal diet, they may have protein restriction, but it must have high biologic value. Kind of like that bioavailability. So they're basically the type of proteins that are complete, and they basically supply the patient with the essential amino acids needed for growth and repair. So growth and cellular repair. That'd be your dairies, your eggs, and your meats. So your dairy, your eggs, and your meats. And what they should be getting a day is 0.6 grams per kilogram per day. Or per body weight, not per day. which equals about 40 grams per day. That's what I was trying to say. Okay, we're going to restrict fluids. And they should have, you know, up to approximately 600 milliliters per day. That's not a lot. You know, and that's going to be based on the urine output from the day before. So, for example, if Friday the urinary output was 200, then what would the Saturday fluid intake max be?
$400.
So it should be up to 600 more than the day before. So primarily 500 to 600 is what the base is. So if we're looking at between 500 and 600 per day, and they put out 200 yesterday, so they can have what they had yesterday plus either 500 or 600. So this would be 700 to 800. Does that make sense? If they don't make any urine, then the doctor's going to determine how much fluid intake they can take. So if, say, yesterday they put out 100 mils, then on Saturday they could do 600 to 700 in PO fluids. Does that make sense? Okay. In water, they should be drinking about 1 to 2 liters a day. That's their generally recommended amount of water. So for water, 1 to 2 liters per day is their recommended. I need to put the liters over here. 1 to 2 liters per day. There we go. What about sodium? How many grams are they going to get of sodium? I'm going to clear this.
2 grams?
2 grams or less per day. So they're going to get 2 grams of sodium per day, and that's going to be adjusted based on how much fluid they retain or how much fluid they gain. Potassium is going to be restricted so they don't go into hyperkalemia, so they're not going to be chomping up a bunch of bananas and broccoli. And they can also manage the potassium through dialysis and medications as well. So their restriction for potassium, they're going to have about 60 to 70 milliequivalents of potassium. And that'll be per day. So the other thing is sometimes people try to use those salt substitutes, but those are high in potassium, so they have to be cautioned about that. Phosphorus intake is also restricted. So this is going to be a quagmire, because if protein, you need the ones of high biologic value. Those ones of high biologic value also have high phosphorus value. So your eggs, your dairy products, and your meats. So they're going to have to really be, you know, super tight on what they're intaking. They need the vitamin supplements because of the protein restrictions. And as far as their calories by carbohydrates and fats, they're going to need those to prevent muscle wasting and maintain energy. So they should be eating about 35 kcal per kilogram. So for calories, 35 kcal per kilogram per, and that's what they should eat each day. All right, so treatments would be either hemodialysis, as we've already talked about, peritoneal dialysis, or transplant. So those are the options. What if you how long does it, let me see, not what if, how long does it take for a person to receive hemodialysis? What do you think they average?
4 hours.
3 to 4 hours, and longer if they have to go slower. So they just can't rip that fluid off and then just, like, okay, thank you. That poor person to be sick, vomiting, and all of that, stomach ache. So, we know we have to check the AV shunt. So we're going to fill a thrill here, brew it. Make sure that it's operational. And usually the shunt is going to be in the forearm, but you know what? I've seen them in so many different places. I've seen one in the wrist. I've seen one in the humerus. They just find a spot. If it's a spot, they're going to take it. So that's, that's kind of the thing. We're going to monitor for signs and symptoms of infection, bleeding, clots, all of those things. Teaching the patient not to lay on the extremity, how to take care of it. So there's a lot of ins and outs to that.
Not to use it for a drug side.
So usually this takes between 3 to 4 hours. All right, so now we have peritoneal dialysis. And so here, where is our tube?
In the abdomen.
It's in the abdomen, it's in the peritoneal space, right? So if they don't want to do hemodialysis or transplant, then they'll consider peritoneal dialysis to remove the waste products and try to, maintain fluid balance. So if they're susceptible to rapid fluid loss or electrolytes or metabolic changes, they're very sensitive to that from hemodialysis, and they may go with PD, which is a little bit more slow. So it's in the peritoneal membrane. So that particular abdominal, the layer that covers the abdominal wall, that membrane is now used as a semi-permeable membrane. So they're going to use dialysate. So they get a big bag of dialysate that they're going to infuse into the peritoneal space through the catheter. And once that solution is in the peritoneal space, then the toxins can be cleared from the blood through diffusion and osmosis, so both processes. So the waste products will be removed from an area of higher concentration to lower concentration through that peritoneum, which is the semi-permeable membrane. So that movement is known as clearance. So the rate for which the substances cross the peritoneal membrane is not the same. It's going to have varying rates. So their dwelling time may have to be adjusted depending on the situation. So you have an in time, a dwell time, then you have an outflow time. And that usually takes about 36 to 48 hours to achieve what hemodialysis does in about 4 to 6 hours. So when they infuse that dialysate in, then it's in the semi-permeable membrane, all the toxins and metabolic waste products shift, and then it goes into another bag that's another see-through bag, for lack of a better word, but it's clear. So my question is, what if it comes back and it looks like very purulent and nasty and cloudy? Is that good? What does that indicate?
Signs of infection.
That's a sign of infection. So that's going to be an issue. Okay. So they have to look at that dialysate to make sure that it's A-okay. And there are so many different types of peritoneal dialysis. So they can do acute intermittent, they could do continuous, they could do a continuous cyclic version. So, and some hemodialysis can also, some other dialysis can be done in the ICU. So CVVHD, which is continuous venous hemodialysis. So there's a lot of different pieces to that. Besides the purulent flow, if the patient has a fever, nausea, vomiting, belly pain, then that's all signs of peritonitis as someone who's already typed up, but it's a sign of infection. They do need aggressive antibiotic therapy. We need to send that dialysate or the drainage for culture and sensitivity. And this must be done when they are connecting that dialysate to their tube, to the catheter. This is a sterile procedure. So if there's if they have frequent peritonitis that happens, then they're going to pull the tube. So the goal of the dialysis is to get the patient within 2 pounds of their dry weight. So that's kind of the goal of dialysis. All right, kidney transplant. So, there's a lot of components that goes into that. So that would be your finding a match, the histocompatibility, and people think once they get a transplant that they're done with medications, but they are really just beginning because they have to make sure they don't end up with rejection and all of those different types of things. And there's different types of cadaver donors, different type of donors. You can have a living donor, a cadaver donor, someone that's died. But, they're trying to make sure, I don't know many people that are donating organs, left and right. So some people end up on that list and they hang out for a long time. And they could potentially die before that kidney transplant ever comes through. So can every patient be a kidney transplant donor? Can all patients? No, they cannot. If a person has like a recent infection, a malignancy, anything that's inoperable, AIDS, HIV, Hep B or C, morbid obesity, those people cannot, they will not use their kidneys. Because they're trying to get those kidneys close to perfect as possible. So things we want to make sure we're following through on is preventing infection, monitoring urinary function. This is when they get a kidney transplant. And it is imperative that they pee because that lets you know that the kidney what? The transplanted kidney works, okay? Look at psychosocial concerns, monitor for complications, teach the patient to monitor for infection, tell them about their medication regimen, that this is going to be lifelong, they're going to be on immunosuppressants, and how those immunosuppressants will affect their body and maybe some body image disturbances that go on, signs and symptoms of that the kidney's rejecting, the importance of routine follow-up care. So that way the person, can maintain that kidney for quite some time. So I think we've covered everything that I could potentially think of on kidneys. What do you guys think? Okay. So when you do have that person that's, kidney dialysis or whatever, then the biggest assessments you want to check is the weight and you want to check the blood pressure. So, if we're having an increase in weight and BP, we know that we've gained a bunch of weight and we may have fluid and electrolyte issues. So if a client gains 5 pounds in 3 days, and their blood pressure has gone up each day, what is your concern there with the fluid increase?
Hypervolemia.
It is hypervolemia, but what's the bigger issue? Because the volume's inside, what's going to start having problems? So if you gain weight, where do you see your trouble areas as far as your ability, your activity level?
Your endurance.
Okay, so your endurance is low. Okay. What about, so what things can take you out the game? Can endurance take you out the game?
No, but it'd make it hard.
I don't disagree. So if you have...
Would you start retaining fluid in the lungs?
So increase fluids. So now you're going to retain it. Your BP is going to increase, but now your lungs are going to be taxed. So our concern here is, does the patient have heart failure? So if that person's gained 5 pounds in 3 days, that fluid isn't going anywhere. So, but this is still related to CRF. And anytime you have somebody with volume overload, and we talked about that even with fluid administration, with volume overload, you have to consider, especially for elderly people, if you're putting them into heart failure, you just can't give it to them till the cows come home. And same thing like kiddos. Because now that can overtax the heart. So then you would be looking, auscultating breath sounds. So you're going to check breath sounds. You're going to check and see if they have any edema. So you're going to check for edema. So those are going to be things that you check for to make sure everything is A-okay. So you're going to check weight. Check BP. So you're basically checking to see if patient has fluid retention.
So a accurate measure, Professor Hudson, of weight gain concerning FVE, would that be a daily weight or I's and O's?
So if you have a person that is, if you're thinking they have weight gain, if they have weight gain, then that would be wouldn't that be more fluid and sodium being retained?
Yes.
Now, if you're giving them something to pull off the fluid, then I would do INOs to get a good, accurate measurement of that fluid balance. Because that's the only way you could do it. Correct?
Correct.
So even though, and heart failure is going to come back up again in perfusion, but with chronic renal failure, they do run the risk of going into heart failure. So we may not have covered heart failure as a whole, and we'll cover it next go round, because we've talked a little bit about left-sided and we've talked a little bit about right-sided prior to when we did the gas exchange. But we have to address the volume overload related to heart failure or a volume overload related to any person, that because it's going to have electrolyte imbalances associated with it. Okay. All right. Last thing I believe is DI. I mean SIADH, not DI. Right?
Yes.
Okay. So let's, before we do that, I'm just going to do just a little quick check to see if you all have studied since Tuesday. So if you have a kiddo that's dehydrated from persistent diarrhea, or, you know, or acute diarrhea, not persistent, but acute diarrhea, how do you know they're dehydrated? What are signs and symptoms of kiddos being dehydrated?
Their eyes will be sunken.
Okay, so sunken eyes.
Thirsty.
Thirsty, poor skin turgor, dry mucous membranes. Okay. Cap
Infants
refill. Cap refill, would that be delayed?
Yes.
So delayed means it has an increase in the number of seconds before the skin returns back to, you know, to its normal, or the blood flow returns back to the area of the skin, right?
Mm-hmm.
So would a fever make this better or worse?
Worse.
It'll make it worse, because when the patient is hyperthermic, then that increases the metabolic rate, which means you're going to have more calories that's going to be demanded. You're going to need more fluids because you're going to be losing it, and you're going to have an increase in oxygen demand. So two pieces. So let's separate them out. So we're going to check for sunken eyeballs. What about the fontanelles? And then you have an interior one and a posterior one. So which one's in the front, which one's in the back, and which one closes first, meaning within 4 to 6 months? So they have fontanelles. They have an interior and a posterior. One closes 4 to 6 months. The other one closes at 18 months. So I said, which one closes first?
The anterior.
Actually,
No, I'm sorry, the posterior. Yeah.
That closes first. This one closes 18 months. So you can still use this as an assessment tool. So if your kiddo is dehydrated, what would you anticipate the fontanelles to be? Bulging?
Sunken in.
Which one?
Sunken in.
It will be sunken. So if it's dehydrated, it'll be this here. All right? Let me go here and just erase that. All right, let me go back here. So if your patient has an increase in ICP, what is ICP?
Cranial pressure.
Intracranial pressure. Then the anterior fontanelle will be sunken or bulging.
Bulging.
This one will be bulging. That doesn't look like bulging. All right. So that's kind of, you know, kind of your guide there. So if they're dehydrated, it's going to be sunken. If they have an increase in intracranial pressure, it's going to be bulging. So the last one I'm going to ask you, if they have a fever and a bulging fontanelle, what condition is this?
Dehydration.
Meningitis. So before you even get to anything else, you have, just on assessment, you should be anticipating that this is what's going to be wrong with the patient based on that information. So back to F&E and dehydration and fluid volume excess. If they're dehydrated, then they're going to have sunken fontanelles, dry mucous membranes. So, you know, they can have diarrhea. Say if they have diarrhea, let me ask it this way. If they have diarrhea and they've had it for 24 hours, but they have had 6 wet diapers, are they A-okay in 24 hours?
No.
Actually, if they had at least 6 wet diapers, they're good.
Oh.
I know.
So it's less than 6 then.
If it's less than 6, we have a problem.
Okay.
Remember, 70 to 80% of their body is water. So any type of illness or acute diarrhea, it's going to deplete their fluids and electrolytes. So kind of going back to the persistent diarrhea, but if they have mild dehydration, how do we rehydrate them? Do we give them IV fluids? Do we give them clear liquids? Do we give them, you know, PO fluids? What do we do? Do we give them IV fluids?
Would you just, if it's mild, would you just do PO fluids?
Yeah, mild to moderate. We can give just oral rehydration, but we're not going to give any of those clear liquids with the sugar because it's too much sugar. So we could do oral, but if we give them anything with sugar, what's going to happen to the diarrhea? Is it going to get better or worse?
Worse.
It's going to get worse. So that's why we're not going to give them anything with the sugar. Okay. So now next case, if they have a fever, then, you know, with a respiratory illness like bronchitis, then we're going to, you know, increase their fluid intake. Makes sense? What is normal urinary output for adults? What are we looking for them to put out every hour? Thirty milliliters per hour. That's what we're looking for. So anything less than 30, is that an issue? If it's less than 30 an hour, is that a problem?
Yes.
Yes. So if I'm telling you that you got to at least have 30 and you only put out 20, 25, then it's a problem. Okay? Because for adults, they should pee out 1 to 2 milliliters per kilogram per hour. So if you have somebody that's peeing out less than this, do we want to give them Lasix?
No.
No.
No, we don't want to give them Lasix because that's going to make them more dehydrated than what they were before. So if they don't have volume and then we give them something that's going to take the little bit of volume they have left in their body out, then we haven't helped the patient. So we're going to stay away from things that's going to increase the dehydration. Okay. Right, furosemide increases urinary output, but if it increases urinary output, then the fluids, where's the fluids coming from? It's not just because your urine is part of your volume as well in your body system. So it would be like if you were to now just out of the blue decide to take your grandmother's Lasix or your mother or your father's Lasix or your sister or your brother's Lasix, and you don't need to, it's going to deplete your body. You're going to become dehydrated. Your electrolytes are going to be off. You're not going to be sitting too pretty. Okay. So what electrolytes are lost with persistent vomiting? What are some of the key electrolytes?
Sodium.
Sodium. Okay, my writing's gotten terrible all of a sudden. All right, so we have sodium, potassium, and what acid-base imbalance would they be in?
Metabolic acidosis.
Yeah,
Metabolic
alkalosis.
acidosis.
Remember, they're vomiting. So they're going to lose sodium, they're going to lose potassium, and they're going to be in metabolic alkalosis. Okay. So if you give somebody Lasix, when should you tell them to take it, or furosemide?
Earlier in the day. You don't want them to take it after 6.
You don't exactly. You don't want them taking it late in the day. You know, late afternoon, 4 or 5 o'clock. They're gonna be up all night peeing. So, you know, we don't want them up voiding all night long because then that means they're gonna have sleep disruption and all kinds of other issues. Okay. You felt like you've been quizzed enough? All right, we have about 30 minutes. And with that 30 minutes, I'm going to do SIADH. So we're going to talk about that. Wait a minute. Somebody has a question. Okay. You clear? Can you guys see this whiteboard thing okay? Does it work okay?
Yes.
All right. I was going to see if you needed me to get rid of it. I don't know if it helps or hurts, but let me know. All right. So remember, our antidiuretic hormone helps us to retain fluid. So it's produced by the hypothalamus, right? That's what we talked about on Tuesday. And this happens when you're thirsty. So when you're thirsty, no, it's produced by the hypothalamus, but when you're thirsty, then the hypothalamus will kick in. So which sodium imbalance do we have? Is it hyper or hyponatremia?
Hyper.
Hypo.
Oh.
It's hypo. Ooh, I didn't mean to do that. Oh. So with With DI, we have what? Is our sodium up or down?
Down. Down.
You all agree?
Yeah.
Yeah.
All right. Yep. It's going to be greater than 145. So is that up or down?
It's up, hyper.
Okay. Someone says, I don't know.
Wait, so is DI hypernatremia?
Mm-hmm.
Huh. Okay.
It is hypernatremia. We have an increase in serum osmolality and we have an increase in hypernatremia. Because what I talked about is if you were to give a person that 3% sodium chloride, if you were treating a different type of dehydration, then you could swing them the other direction. But they are hypernatremic.
So a patient with DI is typically hypernatremic or hyponatremic?
PER.
Oh, okay.
I keep turning off my, oh, I wish I would quit doing that. So hyper. So if they have SIADH, and here we have increased sodium excretion, so then they're going to have low sodium, less than 135 milliequivalents per milliequivalent with a Q per liter. So here we have an increase in antidiuretic hormone. Here we have a decrease in antidiuretic hormone. It's missing. So when we have an increase in antidiuretic hormone, then the renal tubes become permeable and retain water. So we have retained water and fluid volume. But it's inside. So we have sodium. So we'll just say we have sodium, but now we dump in a bunch of retained water. What happens to the sodium? It becomes dilute, correct? So this goes back to, and I think I made this inference right before we left, when we had the hyponatremic euvolemia, and you're like, how is that possible? But the dilution was inside the rates of those, or the rates were completely different. So it's not to say that they had an equal balance. So this is kind of the same situation. So we end up with a dilutional hyponatremia. I'm going to clear that. What about our aldosterone? Is it going to have an increase or decrease in secretion? It'll be decreased. So aldosterone secretion decreases. We have a decrease in sodium reabsorption. Which means an increase sodium excretion. Hence, decreased sodium or hyponatremia. If the sodium is too low, and this is the sodium, then the patient will start to experience cerebral edema. So that means if it's less than 120, and this will have a high mortality. So now let's be clear. Regardless of SIADH, if the patient's sodium level is less than 120 and they do not have SIADH, cerebral edema is still your concern. It still has a high mortality rate. And the thing you want to monitor for is going to be seizures. And especially and not just kiddos, it's going to be in both parties. But in kiddos, you're going to put them on seizure precaution. You're going to put them on seizure precautions in anticipation that they're going to potentially develop this cerebral edema because their sodium level is less than 120. Does that make sense? Okay. Everybody have that? Or if you don't understand it, this would be the time to ask the question. Because otherwise I'm going to presume you understand. Okay. So with SIADH, there is an increase in the amount of antidiuretic hormone being produced. Does that part make sense? Now, why do we have an excess in ADH? It could be that the hypothalamus is damaged. It could be that the posterior pituitary is damaged. It could be that the antidiuretic hormone isn't being produced by the hypothalamus. Either way, we have an excess in this process. So when we have excessive secretion, then our renal tubules become more permeable, and they're going to end up retaining more water. So now your patient has water retention. Sodium that's in your body, if it's now being flushed or flooded with water, becomes diluted. So that's your hyponatremia. But as the water continues to form or be retained, we also have a decrease in our aldosterone in the production of sodium, because isn't that aldosterone's role is to sodium production? So if that's down, then we are unable to replace the sodium that we're losing from the dilution, which continues to maintain the hyponatremia. Does that part make sense?
Yes.
Okay. So what I'm saying here is the aldosterone has a decreased secretion in sodium. And if we're not making sodium, there's no sodium to be reabsorbed. So the sodium that's there is being pushed out in the urine, so we're peeing it out. Hyponatremia. With a person whose sodium level is less than 120, so when the sodium is too low, our biggest concern is cerebral edema, and that's going to be because there's a fluid shift. With that fluid shift, when we're monitoring patients for hyponatremia, we're monitoring them for seizure precautions related to the cerebral edema. Does that part make sense?
Yes.
Okay. So with kiddos, we want to put them on seizure precautions. Even with adults, we want to put them on seizure precautions because we are anticipating that if the sodium levels are low, they are moving towards cerebral edema. Does that make sense?
Yes.
Okay. Now are we all on the same page?
Yes.
Okay. So if not, somebody need to go ahead and, send a chat or something. Okay. If a person has an acute decrease in sodium in 48 hours, in less than 48 hours, so in less than 2 days, they have an acute decrease in less than 2 days in sodium, what do you think is going to happen to them? Do you think this is an emergency, or are we good? $50-50 chance. Okay. We have 50-50, emergency and good. It's actually an emergency. If the sodium drops significantly in less than 2 days, the patient's going to end up with a herniated brain. So from that, they'll have unilateral pupillary dilation. So one pupil would be huge, one pupil would be tiny. So this would be an emergency. All right, so what are our causes of SIADH? So causes would be head trauma. So this bothers me when I do that. So we have head trauma. Oh, will you quit? Move that over there. Closed head injury, as an example. Stroke, lupus, older age, AIDS, So we have cancer or neoplasms, and like pancreatic, Hodgkin's, lung cancer. And this one would be the oat cell or small cell. Asthma can do it to you. Atelectasis, and MI. So that list just can be humongous. Meningitis. I'm just going to come up here. Multiple sclerosis. Okay. All right, so signs and symptoms. Water retention, because we just talked about that. If we're retaining water, then we have fluid volume excess, right? And if it's up, our blood pressure's up, our heart rate's up. But we have decreased sodium. And the patient's going to be euvolemic, or can be. So how do you know that you're moving towards cerebral edema? What would be the mental status?
Confusion, lethargic.
Confusion is definitely an issue because and the reason why is because and this is because the patient has water on the brain. Mm-hmm. So other things we're going to look for is seizure. They will be anorexic. They're not going to want to eat. How about their urine-specific gravity?
Would it be high?
It's going to be high. Remember, they're not diluting out the urine, but we're going to have concentrates in it, or solutes. How about urine sodium? Would that be low or high?
High.
It's going to be high because you're peeing it out.
Ms. Hudson, is it safe to say that if your specific gravity is high, then that means your urine
is concentrated?
Like, would it always be opposite? Or not necessarily? So if my urine specific gravity is low, then
you have polyuria. Is that what you're trying to say?
Yeah, like, is it safe to say that it would always be the opposite?
I'm not sure if we can actually do that because I'm not really sure, and I don't want to say yes. It appears to make sense in that nature. When you're dehydrated and you don't have enough volume, then your urinary output is low. So I could see that. I mean, it's plausible. All right, so this patient, although they have extra water that's retained, they're not going to have dependent edema. What about their deep tendon reflexes? Would those be sluggish or hyperactive?
Sluggish.
They're going to be decreased or sluggish. Their respirations will also be altered. They'll have something called Cheyne-Stokes respirations. So I'm going to clear this. All right, so labs. So sodium will be less than 135. And what about their serum osmo? And then their urine osmo. So this will be 100 greater than or equal to 100. And this is serum is going to be less than 280. So want to be high and want to be low. No. Cerebral edema and hydrocephalus is not necessarily the same. Remember, keep all of this separate. Don't force yourself not to group anything together. Once you start grouping, then you're going to end up with confusion. So keep everything in its respective silo. All right. So our urine is high because we have decreased urinary output or urinary volume. Because they're euvolemic. And then we have decreased plasma osmo, or increased plasma volume, not osmo, but increased plasma volume. What else do we want to check? BUN and creatinine. We want to check that. We could do a CT of the brain. All right. Diet. We're going to give them a bunch of fluids. We're not. We're going to restrict the fluids between 500 and 1.5 liters per day. What kind of diet? High or low salt? Which one?
High.
We want to give them high salt. So we want to give them high salt or high sodium, high protein. Or you can give them urea supplements. To increase water excretion. All right, so we're clear here. Treatment, what are we going to give them? Demeclocycline. Lithium.
Isn't lithium a psych med?
Mm-hmm. Medications to be given for more than one issue. So if we have volume overload, we can give them furosemide. or if they have heart failure. Oops. Couldn't spell failure. I failed to spell failure. And they'll do this treatment here. Why are we giving diazepam? When would we give the diazepam? If they had the seizure, right? But we're going to monitor their levels to make sure we don't miss the boat. But we're going to need an IV because we may need to give them 3% sodium chloride. And that's if the sodium is less than 120. So instead of using water to dilute tube feeds, they would probably use saline to dilute tube feeds and to mix the meds, because remember, we're restricting water. If they have weight gain, and this is, you need to understand this. If they have weight gain, 2 pounds per day, or it's gradual, have a gradual increase over several days. Are we concerned?
Yes.
This is a major concern. So 1 kilogram is equal to 1,000 milliliters, or 1 liter. So 1 liter. So we're going to correct the sodium deficiencies. We're going to put in a Foley. We're going to check labs. We're going to provide comfort measures for thirst. Get our daily weights. Check our skin turgor. Put them on the anti-embolic stocking, so the SCDs or the TEDHOs. Seizure precautions we're going to institute. We're going to auscultate breath sounds. Then we're going to give them either the democlocycline or declamycin, or lithium, or loop diuretic, depending on the situation. So they have something called the Vaprisol, or the Conivaptan. That's a vasopressin antagonist that promotes water excretion without the sodium loss. Monitor for fluid overload. Check their LOC to make sure they don't have a decrease in neurostatus, and we're going to check that every hour. The declamycin, what it does is it blocks the antidiuretic hormone action in the renal tubules. Therefore, we'll see an increase in urinary output versus a decrease. What happens if your patient doesn't take the medication that they're supposed to? Will they end up with water intoxication?
Yes.
Absolutely. So if they don't take it, then they're going to have water intoxication secondary to the fluid retention. And they're at, what are they at risk for then? Because now the sodium would be super low, right? So what's that concern that we'd be worried about? Cerebral edema? Because if they don't take the medicine, if they have SIADH, they don't take the medicine, do they not still have SIADH?
Yes.
Okay. So if we are now back in SIADH, then our same concerns of cerebral edema and seizures is going to be there. So we need to try to prevent that, to correct that electrolyte loss. All right, you guys sound like you about passed out. So it's 2:04. Finished up just in time. For math, I'll address math. I'll do a small Zoom session on math next week. But look at drugs that you have to reconstitute. And I'll just say, when you're reconstituting a drug, the only product you care about after the reconstitution is what the end product yields. So it doesn't matter what the drug is. So if the drug is, you know, it says you're going to give erythromycin, you're ordered to give 600 milligrams, and erythromycin comes, 1,200 milligrams, but now you have to dilute it with so many milliliters. But if your final yield after the dilution is 300 milligrams per 3 mLs, that's the only thing you care about. Does that make sense? So whatever it was before you reconstituted the drug, it doesn't matter. It matters more what you got after the reconstitution. And then that's the numbers that you use to solve the math problem. Does that make sense? All right, so let me show you real quick. Whiteboard, share. Okay, so if you're to give a drug and say you're going to give erythromycin, this is what you're ordered to give. And you need to give the person, we'll say 650 milligrams. Okay, so it's supplied in a powder, 350 milligrams. Okay, but you need to reconstitute with, we're going to say 5 mLs of saline. So after reconstitution, and it may say, it could say yields. So after reconstitution, the yield is 275 milligrams per 2 milliliters. Does that make sense up to this point? I'm just going to put my little... All right, so I don't care about this anymore. This is just, all this is badookadook. This is extra information. The only thing I care about is this here and this here. So I have 275 milligrams in 2 milliliters, and I need to figure out what 650 milligrams, how many milliliters that's going to yield. I'm a ratio and proportions gal. If you're a formula person, do formula. If you're a deep A person, dimensional analysis, then do dimensional analysis. I don't care how you get it or how you decide to do it. It's totally up to you. So 650, because of how I do math, this would be 275 milligrams X equals 1,300. And then I would divide both sides by 275. right? And so then my final answer here would be the 1,300 divided by the 275. And that's going to be 4.72 milliliters. So I have 4.72 milliliters. Well, if you're given anything greater than 1 mil, you're going to round to the tens place. So this would be 4.7 would be your final answer. If you're given anything less than 1 mil, then you're going to round to the hundreds place. So if you get an answer that's 0.6737, then what would be your final answer if you're going to round to the hundreds place? It would be 0.67. This is your tens. This is your hundreds. And I think this is your tens of thousands or something like that. But in order to get this number to the hundreds, you got to carry it out one more decimal place. And the same thing here. So you're going to go 3 decimal places to get that 1, to get to the hundreds. And then to get to the tens decimal place, you got to carry it out 2. Does that make sense? So you guys need to look in your Hinky book. These rules are in there. Trust me, I've been all through that book. That's how I did the Zoom sessions. But the rules are in there. You can't say, I don't have time to look for it. You will have math on this exam. You will not have heparin though. So but you will do something like, the patient weighs 22 pounds. The medication is, X med, 10 milligrams per kilogram. And then you would have to, calculate what the weight is from pounds to kilograms, or convert from pounds to kilograms, then do your math based on that. Oh, I don't know why that's happening. There we go. I was like, I don't know why that's happening. So I did ask Mrs. Johns about that for clarification. So that way, and we can work some problems, next week, but there's no heparin drips. It's just basically things like reconstitution, things like, how many teaspoons is in a milliliter, or how many milliliters in a teaspoon. It's those types of things. If you're doing an IV drip, somebody's asking me, then that should always be a whole number. So although in clinical, the pumps are specific and you can deliver 12.2 milliliters per hour, for these math tests, we do not base it on the specificity of the pumps. So anytime you're giving a drip, so anything drops per minute, anything's milliliters per hour, it'll always be a whole number. So it'll be 10, 12, 25, 62, 122, 125. It will never be a 120 something point anything or 2 point anything. It's going to be a whole number. And that's for drips. So hopefully that clear up some other questions or concerns. All right. So if there isn't anything else, then we will catch up on Tuesday.
Thank you.
You're welcome. Have a good weekend.
Thank you, Ms. Hudson. Thank you.
Okay, bye-bye.